Human herpes virus 4 is also known as the Epstein-Barr virus, or EBV. EBV is best known for causing the infectious mononucleosis, or commonly known as mono. Mono is short for infectious mononucleosis. Mono is referred to as the kissing disease because it is commonly transmitted through saliva in teenagers between the ages of 15 and 20. In mono, you will see patients present with fever, fatigue, pharyngitis, cervical lymphadenopathy, this one's key, and hepatosplenomegaly, HSM. So anytime a patient is presented on your step 1 exam as a 16 or 17-year-old male or female with fatigue, malaise, sore throat, lymphadenopathy, should be immediately thinking of mononucleosis. Another key point in regards to mono is, as a physician in the future, when you have a patient with mono, why do you have to advise him or her that they cannot be playing contact sports within a month or two after a mono infection? Do you remember why? It's because it can lead to splenic rupture, a serious and life-threatening complication. In general, mononucleosis resolves without issue, but if the patient has splenomegaly and they play contact sports, they can have splenic rupture and they can have some serious complications as a result. So now, thinking back to the transmission route, we talked about it, that is, it's transmitted through saliva. But what cells in the body does EBV, or the Epstein-Barr virus, infect? The EBV virus infects B cells through the CD21 receptor. Remember that CD is short for cluster of differentiation, and all it means is it's a cell surface receptor that's used to identify specific immune cells. CD21 is specifically used to identify B cells. You can kind of remember this because EBV affects young women or men at the age of 21 or so, and so you can remember that 21 is the receptor that is bound by the EBV virus to infect B cells. The next big question we have to answer is, how do we diagnose EBV infection? Well, the diagnosis can be made in one of two ways. The first way is you can look at a peripheral blood smear. Peripheral blood smear would show atypical lymphocytes. Or we could do, and something you're more likely to be tested on, the monospot, or the heterophile antibody test. So here's an image of a peripheral blood smear that shows an atypical T lymphocyte. This is an atypical T lymphocyte that is pathognomonic for an infection with EBV. Why do we know that this is atypical? Well, if you remember back to your histology, lymphocytes are typically round cells, and their nuclei take up most of the cell cytoplasm. So when we see a lymphocyte, we usually see the cell, and then the majority of it is going to be this dark nucleus taking up most of the cytoplasm. In this cell, we see the dark nucleus here, but we also see all this extra space surrounding the nucleus that is extra cytoplasm that is atypical for a TIMI lymphocyte. And also we can see that it's not round, it's misshapen, polygonal, certainly not a round cell. Now you may be asking yourself, why is the T cell atypical and not the B cell? Remember, the B cell is what is infected by the EBV virus. Why is it that the T lymphocyte is the one that becomes atypical? And this is something that they can commonly ask on the boards, is they'll ask which lymphocyte becomes atypical after an EBV infection. Is it the B cell or the T cell? Although the EBV, or the Epstein-Barr virus, infects B cells, the cells that are atypical are the cytotoxic T cells, as we just mentioned. And this is because the T cells are activated in response to the B cells that are infected with EBV. So the B cell is infected, it looks funny, the T cell is activated and becomes atypical as it responds to this B cell that's infected with the virus. The second way in which we can diagnose a EBV infection is with the monospot test. In the monospot test, we take a patient's serum, so a patient that may be infected, so the patient of interest, or we add it to red blood cells, a specific batch of red blood cells from sheep or horses. And we look, or we assay for, agglutination. Do you remember what agglutination is? Agglutination is the clumping of particles, or it's the clumping of the red blood cells together. And this is, you can remember this by its aglue. The red blood cells glue themselves together in the process of agglutination. And it occurs when an antibody is exposed to its appropriate antigen. In patients with EBV infection, their immune cells produce antibodies that bind antigens that happen to be found on sheep or horse red blood cells. Now, don't ask me how they figured this out, but that's what it does, is the serum of the patient has antibodies that are produced by B cells that are responding to the EBV infection, and these antibodies in the patient's serum react with red blood cells from sheep or horses and cause agglutination that we can measure in a machine that gives us a positive or negative result. If the agglutination is positive, we can say that the patient is infected with Epstein-Barr virus. As with other herpes viruses, the Epstein-Barr virus remains latent in your B cells and will be there for the rest of your life. Just as herpes simplex virus 1 establishes latency in trigeminal nerve, this virus establishes latency in the B cells. The last thing we need to talk about in regards to the Epstein-Barr virus is that this virus is actually an oncovirus, meaning it is associated with malignancy. Most specifically, it's associated with this malignancy seen here. Do you remember what this is called? This is Burkitt's lymphoma. EBV is associated with Burkitt's lymphoma, a type of non-Hodgkin's lymphoma. If we think back to our hematology section, what chromosomal translocation is associated with Burkitt's lymphoma? There'd be a translation from 8 to 14. Very good. High yield fact there for Burkitt's lymphoma. The tumors we see in Burkitt's lymphoma are endemic to Africa and are usually seen in the face, as we see in this child. This is a solid tumor that's composed mainly of malignant B cells, which are typically the cells that are infected with EBV. The other cancer that is associated with Epstein-Barr virus is, do you remember? It's nasopharyngeal carcinoma and is often seen in patients of Asian descent. We can also see lymphoproliferative disease in transplant recipients. So it is important to remember that EBV is an oncologic virus, meaning it is associated with malignancy or cancer, and it can cause one of three malignancies, in particular, Burkitt lymphoma, nasopharyngeal carcinoma, and lymphoproliferative disorders in patients that have had a recent organ transplant. Human herpes virus 5 is known as cytomegalovirus, or CMV. This is another very important herpes virus because it is very common and can cause a wide variety of diseases that the Step 1 examiners will like to test you on. In the United States, up to 60% of the population have been exposed to CMV and carry it in their bodies. It is important to remember that this virus does not typically cause disease in an immunocompetent patient. It will only cause disease in patients that are immunocompromised. With that said, it does cause a form of disease that we'll talk about in immunocompetent patients, but the real scary complications of CMV infection are only seen in patients that are immunocompromised. In these patients, it can cause a pneumonia, it can cause an inflammation of the retina or retinitis, it can cause inflammation of the colon or cause colitis, it can even cause esophagitis or infection of the esophagus in immunocompromised patients. In the immune-competent patient, CMV causes a disease that is similar to the mononucleosis seen in EBV infection. This shares some similar features such as, can you remember the important symptoms of mononucleosis again? Fever, fatigue, pharyngitis, and painful cervical lymphadenopathy are key clinical features seen in mononucleosis. Now, the way you differentiate CMV and EBV mononucleosis is that monospot test that we recently discussed. Now, thinking about the monospot test, do you remember how EBV and CMV would differ on this monospot test? Well, we remember the monospot test gives us a positive or negative result based on the agglutination that is seen or not seen when the patient's serum is mixed with red blood cells from horses or sheep. In a patient with EBV, we see a positive monospot test And in CMV, it's the opposite. We see a negative monospot test. So in a patient with symptoms concerning for mononucleosis, in a monospot test that is positive, we know they are infected with EBV. In a patient with a negative monospot test, they are likely infected with cytomegalovirus. Another clinically important feature of cytomegalovirus is that there is a congenital form of the disease. So it can cause a disease in immunocompetent host, which is the mononucleosis, can cause disease in immunocompromised host, which is the pneumonia, colitis, esophagitis, etc. And it can cause disease in a congenital form. It is considered one of the Torches infections. It is the C in the Torches infections, and it causes a classic tetrad of symptoms, including a petechial rash, seizures, hearing loss, central nervous system deficits. So CMV infects the brain, the ears, and the skin. So putting it all together here, I know it can seem like a lot. CMV causes a unique set of disease in newborns, immunocompetent, and immunocompromised individuals. If you can remember all these three different disease presentations in the distinct clinical populations, you have cytomegalovirus down, and you'll be ready for test day. Here we see a classic pathologic tissue specimen of CMV infection. The diagnosis is made by visualizing infected mononuclear cells with Al's eye inclusion. You can see here, this is a cell that's infected that has this inclusion body that looks like an owl eye. This is a high yield image. It's one you should definitely be familiar with and be ready to evaluate or interpret on your step 1 exam. Human herpes virus 6 and 7 are similar, and therefore they are grouped together here. These viruses both cause roseola infantum, although HHV6 is a more common cause of this disease. This syndrome is characterized by extremely high fevers that is then followed by a diffuse red macular rash. The key clinical feature here is that the fever is very, very, very high. It is so high, in fact, that can actually cause seizures in young children. Classically, the rash starts on the chest, back and abdomen, and spreads to the extremities. Do you remember how this differs from measles and rubella, other important rashes of childhood? Well, measles and rubella, their rashes start on the face and then spread. Another important feature of this rash for HHV 6 and 7 is that it's generally not itchy or uncomfortable and will resolve after several days. Human herpes virus 8, or HHV 8, causes, most importantly, Kaposi's sarcoma in immunocompromised patients, typically in patients that have been infected with HIV that has progressed to AIDS, or in somebody that has had a transplant of some sort. Kaposi's sarcoma lesions are angioproliferated because the virus infects endothelial cells of blood vessels, causing dark violaceous papules or plaques that represent vascular proliferations. So these are vascular proliferations because the virus infects endothelial cells. These lesions are often seen on the skin and they're seen by the world, but they can also affect the GI tract as well as the lungs. Now, thinking back to bacteriology for a second, do you remember which bacteria causes a disease that can resemble Kaposi's sarcoma? The disease is bacillary angiomatosis, which has to do with blood vessels, that is caused by the bacteria Bartonella henslei. Very good. So in order to differentiate between Kaposi's sarcoma and bacillary angiomatosis, sometimes a biopsy of the lesion needs to be taken to examine for bacteria. Flash quiz time. Can you tell me, how does the monospot test differentiate between EBV and CMV mononucleosis? Well, remember, EBV has a positive monospot test, while CMV has a negative monospot test. Remember, the monospot test takes the patient's serum, their blood without red blood cells, and mixes it with red blood cells from a sheep or a horse, looking for that agglutination. If there is agglutination, the test is positive, and if there isn't agglutination, the test is negative. Positive means EBV, negative means CMV. Very good.